You know the feeling. You're a hepatologist or an intensivist, standing right there at the bedside, and managing a critically ill liver failure patient feels exactly like walking a therapeutic tightrope. You're actively balancing systemic inflammation, multi-organ failure, and intense hemodynamic instability, and the whole time the clock is just ticking. So today in this explainer, we're zeroing in on the precision use of two absolutely crucial extracorporeal tools: Therapeutic Plasma Exchange, or TPE, and Continuous Renal Replacement Therapy, or CRRT. We're going to break down exactly how to use these modalities, not just as a desperate last resort, but as a carefully calculated bridge to recovery or transplantation. Here's a quick look at our clinical roadmap for today. We'll cover the extracorporeal tightrope, optimizing TPE modalities, CRRT and ammonia clearance, sequencing these therapies, and finally, biomarker-guided precision.
All right, let's jump right into Section 1, the extracorporeal tightrope. Let's really look at the clinical stakes here.
More than 50%. That is the mortality rate we're frequently staring down when a severe loss of hepatocytes cascades into full-blown systemic inflammation and multi-organ dysfunction. When standard medical therapy just isn't cutting it, rapid and precise extracorporeal intervention is no longer an option. It's a critical, literal lifeline. And we're not just running the blood through a machine and broadly hoping for the best, right? In acute liver failure, or ALF, TP is actively clearing damage-associated molecular patterns, DAMPs, which are released from massive hepatocyte necrosis. Now, in acute-on-chronic liver failure, or ACLF, we're targeting PAMPs from bacterial translocation to stave off sepsis. In both scenarios, we're pulling out inflammatory cytokines like IL-6 that are driving the vasodilation and endothelial dysfunction, right? Alongside protein-bound toxins like bilirubin. Reversing that specific molecular chaos, that's the whole game. Moving on to Section 2, let's talk about optimizing those TPE modalities. The crucial thing here is choosing the right machine for the right patient. We basically have two options: centrifugal TPE and membrane TPE. Centrifugal TPE separates blood by molecular density. It achieves up to 80% plasma extraction and operates at significantly lower blood flow rates. We're talking 50 to 100 milliliters per minute. Membrane TPE, on the other hand, relies purely on filtration. It demands much higher flow rates, around 150 to 200 milliliters per minute, and comes with a higher risk of activating blood cells and inadvertently worsening the inflammatory environment. If you look at the distinct circuit pathways shown here, you can see why this matters. Because membrane TPE demands those higher blood flow rates, it can so easily provoke hemodynamic instability in a patient whose microcirculation is already hanging by a thread. Centrifugal TPE, because it operates at lower flow rates and has less inflammatory activation, is repeatedly shown in the data to be the safest path for these hemodynamically fragile liver failure patients. And one size definitely does not fit all when it comes to dosing. For a patient with severe acute liver failure, we lean hard into high-volume TPE. That means exchanging 8 to 12 liters, so 1 to 1.5 plasma volumes daily for 3 to 5 sessions. You want rapid, aggressive clearance of those protein-bound toxins. But for an ACLF patient, their physiology is much more precarious. So we scale it back to standard volume TPE. We're talking a much tighter 2 to 4.5 liters, usually just 1 to 2 sessions a week. This prioritizes their hemodynamic safety while still clearing out that inflammatory burden. Okay, Section 3, CRRT and ammonia clearance. Let's look at the other major pillar of our strategy. Amidst the constant symphony of machine alarms in the ICU, timing your intervention is literally everything. The strict clinical indications that should prompt you to initiate CRRT are progressive or hyperammonemia-driven hepatic encephalopathy, acute kidney injury, specifically stage 3 AKI, with progression or non-response to vasoconstrictors within 12 to 24 hours, and of course, severe fluid overload that is completely unresponsive to diuretics. 40 to 75%? That is the ammonia clearance rate you can achieve in just 24 to 48 hours using high-volume CRRT. For an ALF patient with surging ammonia levels, this intervention isn't just about managing the kidneys. It's a vital, highly time-sensitive maneuver to halt the progression of cerebral edema.
Section 4, sequencing and combined therapies. This is where it gets tricky.
When you've got a patient requiring both TPE and CRRT, how do you deploy them without completely overwhelming their system? Well, the evidence strongly points toward a sequential approach as the safest route. Step 1. Run a standard volume TPE to rapidly clear out those large protein-bound toxins and inflammatory cytokines. Step 2. About 12 hours post-TPE, you initiate CRRT, typically CVVHDF, for preemptive ammonia control and fluid management. This sequential flow manages fluid overload meticulously without totally shocking the patient's circulatory system all at once. But what about combined tandem therapy, running them both at the same time? The data is crystal clear here. This should be strictly reserved for true rescue scenarios. We're talking fulminant cases with cerebral edema, or ACLF patients in severe septic shock, where simultaneous toxin clearance is absolutely non-negotiable. You have to be incredibly cautious, because combining these therapies carries a 10 to 15% increased risk of fluid overload, not to mention elevated risks for citrate accumulation and catheter complications.
Let's consolidate this risk-benefit calculi for a second. Look at the balance. TPE monotherapy gives you rapid toxin clearance and immunomodulation, but it carries bleeding and infection risks. CRRT manages the fluid and ammonia beautifully, but brings its own bleeding and circuit clotting risks. Combine them, you drastically increase the complexity, the cost, and that critical risk of fluid overload. This summary right here is basically your bedside tool for weighing those exact benefits against the perils of hemodynamic dips and citrate toxicity. Finally, Section 5. Biomarker-guided precision therapy. This is where the field is heading.
We're moving away from purely reactive medicine and starting to see the emergence of highly specific, actionable biomarker thresholds. An interleukin-6 level greater than 100 picograms per milliliter is now heavily linked to severe systemic inflammation and a poor response to standard medical therapy in ALF. And in ACLF, urinary NGL levels above 900 nanograms per milliliter have been shown to be specific for predicting non-response to terlipressin and hyporenal syndrome. These aren't just arbitrary numbers. These are emerging gold standards designed to trigger timely, personalized extracorporeal intervention before irreversible multi-organ failure sets in.
Notice how this clinical pathway splits right from the start based on the distinct pathophysiology of ALF versus ACLF. It guides you through the specific indications for TPE, CRRT, and those rare rescue indications for combined therapy. It forces us to ask the right questions. Is there severe coagulopathy? Is the fluid overload unresponsive? What's the MELD score? It integrates the exact volume regimens and those critical monitoring parameters into one cohesive, actionable protocol.
Which leaves us with this final, somewhat provocative thought. As we keep refining these therapies, will universally validated biomarker cutoffs, paired with AI-driven dynamic prediction models, eventually eliminate the clinical guesswork entirely? I mean, if we can perfectly time the initiation, the modality, and the sequencing of extracorporeal life support based on real-time molecular feedback, we might just permanently change the landscape of liver failure survival. It's a fascinating future. Thanks so much for joining me for this explainer, and I'll see you next time.